Hey there, everybody. Good afternoon. Guess what time it is? It is 4 o'clock in the mountains, which means 6 o'clock on the East Coast and three on the West. And there is only one place that you are supposed to be right now, and that is right here. My name is Dr. Randy Fink. I am Fink. You are friends, and this is Fertility with Fink and Friends. We've got a couple of different Instagram feeds here. We've got Facebook and YouTube and LinkedIn right here in the middle. Good afternoon to everybody. It's Tuesday, and it is my favorite time of the week. It is that time that we get to get together and talk about all those things that are important to each of us. And that is the business about making families, about women's health and making families and all that stuff that goes along with it. So, who do we got? Doc Sherry, good afternoon to you. Hey to Crystal and Jenny, hello. Thank you for sending greetings. Macro Mama, Staley, good to see you. Fink, well, that makes me happy. 3 minutes after the hour, and we are going to be here for the next hour answering your questions and talking about all those things that are important. The first thing, and we'll jump right into questions here in a minute, but I want to answer something that I have been hearing a lot in the last few days, and that is folks talking about ovulation predictor kits. Ovulation predictor kits are basically little strips that you can buy in the pharmacy. You can buy them from lots of different places. You can get them from Costco in bulk, and they are something that you test your urine with. And what they're testing for is luteinizing hormone, LH. Luteinizing hormone starts to go up. It surges, as we say, when you are going to ovulate. And so, as an ovulation predictor, doing this urinary LH test gives us a clue as to where you are in your cycle and when you're going to release your egg. It helps if you're doing timed intercourse or things that require us to know where your ovulation is. It gets us to be able to know when that ovulation is occurring by looking for your LH surge. These tests are notoriously inaccurate. They are frustrating to use because if you're testing a little too early, then you may miss the LH level going up, and if you're testing too late, you may have missed it outright. And sometimes your LH level will start to go up, but you don't actually ovulate, which is a type of ovulatory dysfunction. So you're getting the surge, but it's just not going high enough to trigger the ovaries to release the egg. And in that scenario, you don't ovulate, but your OPK, your ovulation predictor kit, may still be positive. So there are other ways. So people, complain about their ovulation predictor kits, and I say 100%. Yeah, they are difficult to use oftentimes, and they are very frustrating because if your cycle isn't, if you're not going to ovulate when we think you're going to ovulate, then you may be testing at a completely different, wrong time of the cycle. There is a newer product that is out that I happen to think is very cool. One of my colleagues, you may know Brandis Montez, our nurse practitioner here, has partnered with this company that's called Inito, 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 and Inito is a thing by which it tests your urine. It's a little stick. You test your urine, but it plugs into a little adapter, I believe, that goes into your phone. It actually reads the level, and then it plots it out on a graph for you. And it also plots out, I believe, your estrogen level and your progesterone level as well. So you get to see actually not only when does your LH surge, but when you are ovulating. I think this is very promising as far as home monitoring. It's a little bit more expensive than a little box of LH strips, but those get expensive as well, to be honest with you. Brandis has a discount if you use a code Brandis15, Brandis 15. It gets you, I believe, 15% off on that. I think it's actually very promising. I think it's pretty cool technology. I'm surprised it's taken this long for it to come about, but maybe you want to take a look at that. It does make testing the hormone levels at home much easier. The problem then comes to interpreting those levels, but that's what we're here for. We are here to help. All right, so let's go to our questions here. Let's see. Crystal asks if endometriosis testing and blood work testing all came back normal, what other testing can I do for recurrent pregnancy loss? I've had 4 chemicals and 1 miscarriage at 11 weeks and 2 days. So in that scenario, Crystal, it's endometriosis typically will cause implantation failure, but it doesn't cause recurrent chemical pregnancies. The first thing that I would recommend, and when you say the other blood work, I presume you're talking about the thrombophilia type test. Those are the things that look for the blood clotting type problems. And I would expect in that scenario, that's probably normal too, because that typically does not cause those chemical pregnancies. So there's 2 things I think of with those recurrent chemical pregnancies. I think of one, is it a chromosomal issue? So I would want to know both your chromosome, your karyotype, and your partner's karyotype, looking for a translocation or something that's incorrect in your own genetic coding. And I would suggest certainly PGT testing your embryos, because then you're going to be taking the chromosomal aspect out of the equation. But the other thing there is the immune system. And that recurrent biochemical pregnancy may be an issue that pertains to your, has to do with your T helper cells. So at the level of the endometrium, at the lining of the uterus, when the pregnancy implants, in many cases, the body may be treating that pregnancy like it's an invader, like it was a foreign body that's trying to take over or trying to move its way in. And in fact, it is, but it's something that we want to have happen, obviously. So the medication that we use for that is tacrolimus or Prograf. Now, my guess, Crystal, is that you've been on Prograf, but Prograf would be probably the most important feature I would think of for treating that recurrent biochemical pregnancy if it's not chromosomal. Because what's happening there, many people's bodies are treating it almost like it's a donor kidney. Like you got a kidney transplant, it's a new kidney that's sitting in there and the body's trying to reject it. Same thing can happen to a pregnancy. And that's why we use tacrolimus in our protocols to try to prevent that immune response happening at the level of T helper cells, T helper type 1 versus T helper type 2. It's the ratio. I don't recommend that you get those routinely tested because it's very expensive, whereas the medication is safe in pregnancy and it's extremely inexpensive. So I think it's a much better idea to just go ahead and treat that. Sharmila asks, I have started my stims since yesterday, waiting to meet you again soon for my retrieval. Outstanding. We will be happy to see you here in the great state of Colorado or wherever your travels may bring you, but hopefully Colorado. That's just me personally. SB Charles says, is mini IVF better? No. Let's talk about that because there's often some confusion in the definitions of what that means, mini IVF. Mini IVF is merely a choice to use a lower dose of stimulation medications. And in fact, if you're using the packages that CNY offers, it is the lowest dose, the lowest cost medication package. If you are a person with normal laboratory values, normal ovarian reserve, and you're using a mini dose, it means that you will get fewer eggs. The mini dose therapy was really best designed for people with diminished ovarian reserve. Now, there are some folks, let's say that you're in your 20s. Well, guess what? If you're in your 20s, the age appropriate dose for you would be in the mini dose range anyway. But let's say that you're a little older than that, you have low ovarian reserve, or what we call DOR, diminished ovarian reserve. Well, the older wisdom with diminished ovarian reserve was that we would give you, or your, doctors would give you the highest dose of medication that they could come up with in order to try to stimulate those ovaries to do something, right? But what we learned from that is that it doesn't usually work that way very well. So the higher dose is not necessarily better. And by that I mean if we give you too much medication, then the ovaries may not know what to do with all that stimulation. They may just kind of shut down. They may not do much of anything at all. So in that scenario, what we've learned is that if we use lower doses, mini dose of medication, then you tend to do just as well as you would with the higher doses, but with a lower exposure to medication, a lower cost, and ultimately, in fact, lower side effects. And some people actually we lower the dose and they do tremendously better than they did at the higher doses. So it is a replacement for high dose medication in the patient in whom a high dose medication would have otherwise been used. And that's typically someone with diminished ovarian reserve. But mini dose IVF for people for whom it is not um, age appropriate or AMH appropriate will end up getting you a significantly, probably significantly lower response. A special hello to the Bama gal and husband. That is none other than my mother and father sitting in Mobile, Alabama. Hi, thank you for being here on this Tuesday afternoon. They watch every week. They tell me they watch. They tell me they watch. I don't know if they really do, but they've learned how to appease me. It's either watching my show or sending cupcakes, and what are you going to do? Let's see. Alicita says, I just had an FET with Dr. Corley. So wonderful in Syracuse. I am 38 and transferred 2 untested embryos. I have Hashimoto's. How often do you suggest intralipids for an immune protocol? Is 400 of an estrogen level too high? No, 400 for an estrogen level is not too high. And in fact, the estrogen level really doesn't matter so much. We are one of the few practices that actually checks it. All you need that estradiol to do for you, Elicita, is to make your lining thick. It's to beef up that uterine lining. That's its job. The number there isn't really so important. Now, the intralipid infusion, which if you haven't seen it, it looks like a milkshake. It's a fat infusion. It's basically an IV version of keto diet. So it's a natural anti-inflammatory. It is very anti-inflammatory, and there is conflicting evidence on it. There are a number of studies that show, wow, it's actually pretty helpful, and it does help people get pregnant. And there are other studies that say, well, you know what, maybe it doesn't do so much. So I think it's actually a pretty good idea. I think it has a very low risk to doing it, and you do it typically a couple days before your embryo transfer. And I generally do recommend a lipid infusion, but I also think that keto makes a difference as well as far as being an anti-inflammatory. So there we go, Alicita. Good luck in the next couple of weeks waiting to get your positive pregnancy test. We'll go over to the Facebook side there in just a minute, but let's see who we have on CNY's Instagram here. I saw a question. Rosa says, love you, Dr. Fink. Oh, well, stop. Okay, one more time. Just one more time. Do you have any statistics about Orilissa working for FET with advanced endometriosis? Is it enough to suppress it enough for FET to work without surgery? The answer is absolutely yes. So that's been studied pretty well, whether we're using Orilissa or whether we're using Lupron or even whether we're using Myfembree. You'll find that 60 days worth of suppression is not enough to cure your severe endometriosis. Absolutely not. It's not going to make a big difference in the long term in terms of your pain or the other things that may go along with endometriosis. However, what it does do is that it turns off the inflammatory marker in the lining of the uterus. And that marker is known as BCL6. And that's what we test for with Receptiva. In the very first month after finishing your 60 days of suppression and going right into an embryo transfer cycle, you will find that your fertility level returns absolutely back to normal, your ability to implant. And so they know that by looking at a euploid embryo. If we have a euploid or a tested chromosomally normal embryo, it gives you a 65% probability of getting you pregnant, right? Well, if you're expressing that BCL6 marker, that 65% number drops down to about 10%, 10 to 12%. Whereas 60 days of suppression with Orilissa takes that number right back up to 65%. So, yep, it makes a difference. But again, not trying to turn off cure endometriosis. 60 days is certainly not going to do that. I'm not sure anything is really going to do that. But will it help you to be able to implant a pregnancy? Absolutely. The answer is yes. Liz Nader says, my beautiful baby girl was born August the 10th at 35 weeks. Congratulations, Liz. That's fantastic. Very healthy and went home right away. Thank you, Colorado Springs. Oh, God, we love to hear those stories. Please, Liz, send me a picture if you would. Viva Amy Lorraine says, I am 35 and feel like doctors have given up. Well, I don't know why that is. I don't know what your history has been there, but 35 is definitely not too old to have a baby. That is for sure. There are lots of things that we can do for you there, Amy Lorraine. So please don't go it alone. That's one of the nice things about being here on this Tuesday afternoon, that we've got really a very, very special group of people who are willing to support you through this process and can, really in other venues tell you their own stories. But 35, my friend, is definitely not too old. Let's see. Reese XX3 says, I am so excited. I start with one of your New York sites when I start my cycle. I heard so many good things. Outstanding. Good. We are excited for you as well. How long after being pregnant is Prograf continued? I would usually continue that Prograf through the first trimester, 12 weeks. There are some people who have had adverse pregnancy outcomes a little further along, like let's say, 16-week rupture of the membranes, for instance. And it was also studied with those poor obstetric outcomes and shown to improve them as well, because some of those are also believed to be autoimmune. So if you have a history of bad things happening to you a little bit later on in pregnancy, you can continue. But I would say for the general population, 12 weeks is where I would recommend. Yanni says, I'm currently day 9 of stims. How big do you want follicles? And any tips on preventing OHSS? So OHSS, let's talk about that, shall we? OHSS, ovarian hyperstimulation syndrome. There's mild OHSS, there's moderate, and there's severe OHSS. To be honest with you, OHSS as a mild syndrome is extremely common, because what does it mean? Well, your ovaries are normally the size of like walnuts. And when we stimulate them, they can grow, big as the size of cantaloupes sometimes, or coconuts. When that happens, you're going to feel that. So really the very first thing that goes along with mild OHSS is just discomfort and bloating. Show me someone who's been through IVF and didn't feel bloated. Pretty much it's par for the course. And so one of the things I tell everybody who comes here, who I'm going to do a retrieval on, is that the bloating may get worse before it gets better. And that's even under the best case scenario. Real OHSS, ovarian hyperstimulation syndrome, happens when, as a result of the hormones effect on the blood vessels is that your blood vessels start to get leaky. And so you start to make a lot of extra fluid, and you can collect that fluid in the belly, and that fluid can go other places. You can collect it in the lungs, you can collect it around the heart, you can collect it in the brain. People used to get very, very sick with OHSS and be in the intensive care units, and a lot of electrolyte abnormalities, damages kidney functions and liver function. Those things can all happen. Fortunately, we're pretty good now about recognizing the risk factors for OHSS and trying to kind of put the brakes on things when we see people that are spiraling a little bit too fast. One of the things that we do in our system is that if it looks like your hormone levels are too high, we will use a medication called cabergoline. Cabergoline, also known as Dostanex. Dostanex helps to prevent the progression to severe OHSS. What can you do at home? Well, you can a lot of electrolytes, so keeping your veins full of things like Gatorade or the sugar-free variety, if that is your choice. Those electrolytes are very good about helping to convince your kidneys to get rid of to normalize things and help to get rid of some of that extra fluid. And the other piece there is protein. So 200 grams of protein is what we recommend in the face of OHSS. That constitutes a boatload of protein, probably more protein than most people are really able to consume, especially, after doing an egg retrieval, you're bloated and you're full, you're not hungry, you may not really feel all that well. So drinking 200 grams of protein is a lot, because a protein drink may have like 30 grams of protein in it. So the idea of having to do 5 of those a day is very unpalatable to most people. But the best you can do is protein and electrolytes, and to try to prevent it from happening overall, Yanni. Lacey over them says, is it normal not seeing a fetal pole 5 weeks and 3 days? Just saw the gestational sac and a small yolk sac. Yes, at 5 weeks and 3 days, you may not see any other evidence of the pregnancy besides just the yolk sac, which confirms for us that it is indeed an intrauterine pregnancy. Now, a week from now, you will see both the fetal pole, and at 6 and 3, you should be able to see a heartbeat. So good luck there. Oh, a special hi to Tiana Montez, who is doing who is back to school in Pueblo, Colorado. Thanks for being here this afternoon. Chef Blackney says, is it better to transfer a 3-day or 5-day embryo for women over 35? Well, so, this is always a challenge to know where the best answer is in that regard. People get pregnant from day 3 embryos every single day. There is nothing wrong with a day 3 embryo. What is the advantage of growing an embryo to the blastocyst stage or day 5? The advantage is, well, it has progressed from being what we call a cleavage stage embryo, and it has grown into a little functioning factory. And when it becomes that little functioning factory, we know that little embryo that could has a higher probability of getting you pregnant. So our feeling here is that if you're limited in the number of embryos, it's better to get an embryo inside of you than it is for that embryo to potentially die in the lab under most circumstances, because you're limited in the number. They may not grow to blast, and then you got nothing to transfer. If you've got a lot of embryos, we say grow them out to blast and do your transfer of a blastocyst, and that will ultimately mean that you will have fewer unsuccessful transfers. And that's really the only difference between the day 3 and the blastocyst, is that doing a blast means a higher probability of pregnancy. If it lived to that point, we know higher chance of pregnancy, which means fewer unsuccessful transfers, because we can't say the same about that day 3. We just don't know what it would do. But at the end of the day, we feel like it's probably better inside of you than not. Hopefully that makes sense. Let's jump over to our friends on the Facebook side. Thank you for being so patient. Tori Collins says, I am currently 19 weeks pregnant. Some of the ladies I kept in touch with after graduating from CNY, their doctors had them listed as high risk just because they did IVF, and their doctors making them do an echo at 24 weeks An echocardiogram is a functional test of the heart, the fetal heart, because they say IVF patients are at higher risk for abnormalities. My doctor doesn't have me as high risk or doing an echo. Should I be concerned? Just want to know your thoughts. Can you see everything from the anatomy scan as far as issues? Some doctors say no. Okay, so first question there is about the anatomy scan. An ultrasound is not perfect. An ultrasound is one snapshot in time. And that's why oftentimes they'll say, well, we couldn't completely see everything. We want you to come back another time so we can complete the anatomy scan. Personally, when I practiced OB, I also like to have people do growth scans if there was any question about how the baby was growing, because more is better. But insurance companies don't like that because they don't like to have to pay for those ultrasounds when there is not good data that says routinely scanning everybody with an ultrasound every 4 weeks improves pregnancy outcomes in the general population. So you may get some pushback on that, and most docs just won't do it because the insurance will say no, and then you end up getting some bill for it, and then you're angry. So uh, an anatomy scan cannot show everything because there are too many functional things in an embryo, in a fetus, that you may not be able to see, or that may be subtle enough that they may be missed. So never think that an anatomy scan, just because it's normal, well, that's certainly reassuring. And what we're looking for there is that reassurance. We're looking for big problems. Sometimes you can see small problems, but unfortunately not always. As far as an IVF patient by necessity being high risk, the answer to that is no. They would be high risk based on other reasons. So, for instance, many providers still, we know that if you're over 35 years old, that's considered to be advanced maternal age. And so outcomes may be different, and many people will treat women with advanced maternal age, or what they used to call being an elderly pregnant person over 35. Isn't that insulting? That if you're over 35, that may be considered high risk. There may be certain other considerations that make people high risk, but just because they went through IVF does not make you high risk. Now, you've invested an awful lot, into your pregnancy there. And so since you've invested so much in the pregnancy, and maybe the doctors say, well, hey, we're gonna treat you as high risk and monitor you extra closely and other things because nobody really knows. Maybe there was a reason you had a hard time getting pregnant, and maybe that hard time getting pregnant is going to manifest itself later on in pregnancy. So they may look at you more carefully. But just because you went through IVF does not mean you are by necessity a high risk pregnancy. Liz Fisher says 2 questions. It's been about a week since I found out that I miscarried our first embryo transfer at 6 and 3. Oh gosh, Liz, I am really sorry to hear that. I had a large subchorionic hematoma. What are the odds of having another one with subsequent pregnancies? The odds are unfortunately high. It happens to about 50% of pregnancies will have some evidence of a subchorionic bleed, or a little bruise basically that collects underneath the placenta. Would not doing Lovenox the next transfer being something to consider? And how long should someone, male or female, be on supplements like from my book before doing an egg retrieval? Okay, so 2 other questions there. In general, if someone has a subchorionic bleed, I personally, for the majority of people now, CNY uses Lovenox, which is a blood thinner, on as part of really even just our level 2 immune protocol. Is it strictly speaking necessary? Well, there's going to be some component of people for whom it is critical that we just haven't been able to identify that subset yet. And so by using on everyone, what we're doing is we're increasing the blood flow that's going to the placenta. That number, 50% of a subchorionic hemorrhage, happens irrespective whether you are on blood thinner or not. So I would not say that Lovenox was the cause of your subchorionic bleed, even though you want to think that, oh, well, something had to cause it. I'm on blood thinner, so clearly that had to be it, right? Well, not really, because it happens to people even who are not on Lovenox. However, for the general population, if you are uncomfortable with being on Lovenox, I would say the baby aspirin is probably a very reasonable alternative that doesn't require the use of Lovenox. So I think you'd be okay in that scenario, Liz. And gosh, I sure am sorry to hear about that pregnancy loss. Now, before embryo egg retrieval, you asked about my book. Thanks for mentioning that. It is called The Vitamin Victory, and you can find an ebook copy of that for the low price of $7 through my link tree, which is linktr.ee. That's Linktree, linktr.ee/ Randy Fink MD. And if you can't remember that, it's in the bio on my Instagram page, Randy Fink MD. So that book also gives you a discount code for a whole bunch of supplements. The recommendation is that really probably the sweet spot's 2 to 3 months of being on supplements before doing the egg retrieval, specifically for the benefit of the egg quality. Again, Liz, God bless, and our thoughts are with you. So sorry for your loss there. Tracy Allen says, "Hey, from Wisconsin, you mentioned our alpha lipoic acid. Upon closer look at the detail, it says if you're taking medications for glucose control, consult your healthcare provider. I'm currently taking metformin, 1500. Is it okay for me to take alpha lipoic acid? The answer is yes, you can. So they're doing different things. The alpha lipoic acid, it can have some effect on people's blood sugar, particularly if you run high blood sugars, but it's an antioxidant, and its job is to kill off free radicals, which are little chemical electrons that are kind of floating around your system there, damaging the cell membranes, which is the very source of inflammation. And so that's what alpha lipoic acid does. What the metformin is doing for you there is that in the IVF world, we use metformin for egg quality, for decreasing some insulin resistance. It lowers the overall hyperestrogenic environment, the high estrogen environment that your eggs may be surrounded by, and that may improve the egg quality. So, yep, they're okay for you, my friend. Nellie Martinez said, "You did my transfer last week, Dr. Fink, and greetings from South Dakota, anxiously awaiting for the beta. It was great to meet you." Nellie, we cannot wait to hear your good news, my friend. Thank you for the reach out here. Vilma says, "What's your opinion on mitochondrial replacement? Is it a good option for older women who want a biological baby?" So that mitochondrial transplant is not something that is available in the United States. There is an operation in the Bahamas, I believe, that does it. And there is an operation in Albania, I believe, that does it. Personally speaking, I don't know enough about it. I don't know enough about their data, about their processes. I know their costs are very high. But if it is something that actually works, I think it's a very good thing. My only other concern, so if you do the one in Albania, you have to go to Albania. I couldn't find Albania on a map, sadly. But you have to go there and do your whole retrieval and everything else there. And I had talked to some folks who went through it, and it wasn't such an amazing experience for them as they reflected to me. But again, it's only secondhand information that I have. And my question about the folks in the Bahamas, supposedly you can do your egg retrieval in the United States and just have some like day 2 embryos shipped to them. But I'm not sure how that works, quite honestly, because shipping those kinds of biological specimens across international lines often runs afoul of customs stuff. And so I'm not sure how they actually do that, Vilma, but But that's what I have to say there. Let's go back over here. Hi to Zaneta from Miami, nurtured Shanna, who, well, I'll say, thank you uh, for the procedure last week. Under what circumstance? So, Shanna brought us some really fantastic donuts and wrote one of the nicest cards I have ever seen. And actually, I meant to send you a text or an email or something, Shanna, to say thank you so much, how much we appreciated that. You are a very kind person, so thank you there. Under what circumstances would you suggest thawing day 3 embryos and trying to grow them to day 5? So, for folks who, if you end up, let's say that you do an egg retrieval and you make a few day 3 embryos and you follow the protocol and you say, all right, well, we're going to freeze these on day 3. And then you go and you do another retrieval and you get a bunch more day 3 embryos and you do another retrieval and you get a bunch more day 3 embryos, and before you know it, you've got a little wagon full of day 3 embryos. That may mean an awful lot of transfers before you get to the first embryo that's even normal. So in that scenario, you've got a whole bunch of day 3s. Let nature help you to decide which of them is going to really be able to get you pregnant. You can thaw them, grow them out to blast. You will lose some of them, and that's what you're expecting. And that's what I mean by nature helping you there. Some people will even grow them out to blast and then biopsy them for PGT. And I think that's fine to do. It is a much better thing, in my opinion, to grow an embryo from day 3 to blast and then biopsy than it is to take a bunch of day 5 blasts, thaw them, biopsy them, refreeze them, wait to get the PGT results back, and then thaw again for embryo transfer. Why is that? Well, every little embryo has a finite amount of energy. It's like an embryo has a little gas tank. And the more you do to it, the more gas it's going to use. By the time it's a blastocyst, it's got a whole little tank of gas there. So thawing it causes it to use some energy. Going through the biopsy process causes it to use some energy. Refreezing it, going through that vitrification process, again, that's what it's called. The freezing process causes it to use some energy. And then thawing it again, causing it. At some point, it's going to use up all the gas in its tank. Whereas if you've got a day 3 embryo, it's still making plenty of gas there, enough that it can sustain it as it becomes a cleavage stage embryo going into a blastocyst. So I think it's better to do it, Shanna, from a day 3 to a day 5 than it is to take day 5s and to try to do something with them. So that's the scenario that I typically see when folks want to thaw day 3 and grow them out. Let's see. If you opt out of taking progesterone, does that give you less of a chance of pregnancy? 1000% that gives you a less chance of pregnancy. Now, the progesterone with an embryo transfer that people commonly use is the progesterone in oil, which is that big old injection you get in your butt. No fun. It is one of the least favorite items of any of any of what we do. The progesterone in oil shot. If you're doing a medicated cycle and you decide not to do progesterone in oil, odds are you will not be getting pregnant. However, so the use of vaginal progesterone is not sufficient to be able to give you enough progesterone to maintain a pregnancy. However, if you are doing a natural cycle or a modified natural cycle, your body is making its own progesterone. And in that scenario, you don't need that extra progesterone. We give you a little bit of vaginal progesterone as a local effect, but you don't have to get the shot. And in that scenario, SB Charles, then you are golden, because again, your body's making it itself. You don't have to get the other. But so if you fear the progesterone and oil shot, or you have some other objection to it, do not underscore, circle, highlight, bold, do not do a medicated cycle. Because if you don't use progesterone with a medicated cycle, you ain't making no progesterone, and so you're not going to get pregnant. Okay, let's see. Shine says currently taking metformin and due to start Omnitrope this week. Are they safe to take? Yes, both of those things are used for improving egg quality. Omnitrope is growth hormone, and the metformin, as we discussed before. Yes, they are safe to take together, and they are safe to take, or we wouldn't have given them to you. What do you think of that? 41 minutes past the hour. We got about another 20 minutes here on Fink and Friends. So happy to have you here. My name is Dr. Randy Fink, and I am the clinical director of IVF services here at CNY Fertility, Colorado. Great to be here like we are every Tuesday afternoon. And it's a blessing that you would take your time to spend with me. So thank you for allowing me the honor of spending my time with you. Let's see what else we got here. Pike, Shilpy Kessler. I think I said it right that time. How long is an intralipids infusion continued after becoming pregnant, specifically if you have Hashimoto's and suspected endometriosis? So I think the Hashimoto's there is more the culprit, Shilpy, if I may call you Shilpy. The Hashimoto's is an autoimmune thyroiditis. The thyroid gland lives right here in the neck. If I were going to feel your thyroid gland, I would come around behind you and put my fingers here and ask you to swallow, and I can feel the thyroid gland there in your neck. Intralipids is typically, I think probably the most important one is the one that's done around the time of embryo transfer, but the full recommendation is that you use it really throughout the first trimester, so kind of through about 12 weeks, I believe, is our protocol. Haboshali, can I do IVF if I have Hashimoto disease? 100%, absolutely. No reason you can't, and nothing to stop you. America Dan, and there's a word after that I can't read. Sorry. All my tests were done at your New York clinic. We're currently in the decision phase for IVF versus IUI. My AMH is just under 2, 1.99, and my other test results were normal. Do you recommend IUI or IVF? Well, that's a really good question. Why would you pick one over the other? Well, sometimes you don't have a choice. So let's say that your tubes are blocked. And if your tubes are blocked, you're not going to be getting pregnant by anything other than IVF, because in IVF, we don't use the fallopian tubes. IUI works for some people. Pardon me. With ovulation induction, IUI can give you up to about a 9% probability of pregnancy per cycle. By per cycle, I mean per menstrual cycle, or really kind of per month. Whereas IVF can give you up to a 65% probability of pregnancy per embryo, and you are likely to make more than one embryo. So what does all that mean? Well, IVF is the fastest, most reliable path to pregnancy, but it's also the most invasive, and it's also the more expensive. Now, fortunately, here at CNY, we're lowest cost IVF in the country, so you could do 5 cycles of IUI at CNY for what it might cost you to do, 1 cycle locally where you are. So we do have the ability to offer people, multiple choices and multiple options, but it's still a cost and it's still expensive. And CNY, granted, does also finance things with no questions asked and no credit check. And gosh, all that is really it's a beautiful thing to be able to do for people. But yeah, it's still an expense. So IUI can work for you. If you'd like to try IUI, I say there's no harm to doing it. Where I see the harm come is in 2 situations. One, sometimes I'll talk to folks, we'll do a consult, and they talk about wanting to do IUI. And so we say, okay, sure. And then they go and do it, and I don't hear from them again until 9 months later, and I get another consult on my schedule, and lo and behold, they've done 9 cycles of IUI. And I'd say, that was a mistake. I would not keep doing IUI if it's not working. So the data shows us that after 5 cycles of IUI, intrauterine insemination, you are at no higher odds of pregnancy than you would be from doing home intercourse. Um, Personally speaking, I think it's a lot harder. It's hard to do anything more than about 3 cycles of IUI. If it hasn't worked, step it up, because by the time you've spent what you're going to spend on 3 cycles of IUI, you're already kind of approaching what you're going to spend for a cycle of IVF that's going to be, hundreds of fold more effective. So, that's kind of the way I look at that, America Dan. Um, I just like saying that, America Dan. The other thing I was going to say there, also depending on your age. So if you are over about 37 years of age, then IUI is not likely to be much more effective than home intercourse. So the success of IUI does also depend on age. So if you're 42, for instance, wanting to do IUI, um, you may have done just as well doing home intercourse. If that hasn't worked for you, then IVF may be the better choice. Okay, let's see. One of the New York clinics had me start vitamins, and now my cycle is 6 days late. Is that normal? Well, it's probably not because of the vitamins. There aren't really many vitamins I can think of that should impact your cycle like that. Ver, Ver, Veronica Cole, 99. Thank you, CNY Colorado gave birth to my baby boy last Tuesday. Oh, yeah. Gosh, that is great to hear. Thank you so much for sharing that, and congratulations to you. Um, can CNY embryologists freeze GV oocytes? GV is a germinal vesicle that is an immature egg, and the answer is yes. Why are oocytes that mature post egg retrieval less likely to fertilize? Because um, they the fact that they well so it kind of depends on what was happening there. Sometimes when we look to see fertilization on day one, we've just missed the window that we looked, and it was there, but we just couldn't see it. If that's the scenario, then that embryo is growing normally. However, if that embryo took a while to fertilize, then it means it's probably not as normal as an embryo that fertilized right away that we could see. And so, therefore, it has a higher probability of either not continuing to grow or having an abnormality. Lindsay asked, I joined late. What supplements should be halted during stims? Well, so there's kind of a long list of supplements that I do recommend that you take. At the simplest level, there's a basic protocol. There's a protocol, evidence-based protocol for those with diminished ovarian reserve. The thing that I see not uncommonly is that some folks are taking L-arginine during a stimulation, and that I do not recommend. It is recommended for embryo transfer, but can cause sort of chaotic growth of follicles during a stim cycle. So I don't recommend that. There's another thing some people take a lot of because they think it must be doing a good thing, and that's something called royal jelly. Royal jelly is actually harmful to egg quality, so please don't take that. Let's see. Looking forward to meeting you next week to get these grapes out and partying with my little guys. That comes from Lindsay. Awesome. That is fabulous. Dr. Anidra Marie Johnson, does an inverted chromosome affect implantation failure? So when you say an inverted chromosome, that I take that to mean what's called a translocation. And a translocation is where you've got, two arms of a chromosome, and this piece comes off and is installed here, and this piece comes off and is installed here. So they're in the wrong place. And that translocation can definitely affect implantation and the growth of embryos. Frida asked, does low-dose HCG versus Menopur, which one is better for older women? Well, at CNY, we usually start with HCG because it is considerably less expensive. And for most people, HCG alone, not alone, but HCG as the source of LH in your cycle um, does pretty well. For most people, it works fine and at a very significant cost saving. So that's why it is part of our medication bundles. Um, there are some people who have issues with egg quality that they try to retrieve and they're just not able to make good quality embryos. If they have been using HCG, then in that scenario, I would recommend we switch it to Menopur. I do believe that Menopur can give us better egg quality. There are some studies to show that, and so I have no hesitance about using Menopur. I love the medication actually. It's considerably more expensive. So I think it's fine to start with HCG unless there's an issue. Now, there are also scenarios where your insurance covers some of the medication. And in that case, they are almost certainly going to cover the Menopur. And then I would say absolutely use Menopur. Grace asks, 5 eggs retrieved, 5 mature, but only 1 fertilized. Is this most likely a sperm issue, or can it be egg quality also? It can actually be both. But when we have poor fertilization, the first thing that I think about is, well, what's going on with the sperm there? So, yep, very good question. Timotopy or Timotop says, and forgive me for mispronouncing your name, I apologize. I had my IVF egg retrieval on July the 20th with you, and I haven't had my period since then. Want to know if this is normal and when should I expect my menstrual period? I was on a Clomid 50 up till trigger, Gonal F, etc. So, yeah, that's unusual. Usually you will get a period about 10 days or so after having your egg retrieval. The scenario where you might not get that period is if you did not make much of a lining. So I would say I would want to look at the flow sheet that we keep on you to see, well, what did your lining measure on the last ultrasound uh, before you had your retrieval? Because in many cases, the Clomid medication has an anti-growth effect on the uterine lining, and that can make that lining thin out to the point where, well, you might not get the period because there was really nothing much there to slough off. That's one of the reasons that I prefer not to use Clomid for ovulation induction cycles. I will use it as an adjunct in IVF stim cycles. But if we're doing ovulation induction, usually I prefer letrozole because it doesn't have the same effect on the endometrium that Clomid does. Heidi asks, what is your suggestion for improving egg quality? 43. And out of 8 embryos, we got only 1 normal, which did not implant. The rest, we were told, will not produce life. Well, so some of that is just going to be the biology. At 43, I would expect really less than 5%. In fact, the number is probably closer to 2.5% of the eggs that you make to be chromosomally normal. Can you change that? Potentially. There is a big list of supplements that is an evidence-based protocol. You can find that. My list is in my little book, The Vitamin Victory, on my link tree. Please go to my Instagram. It is in that link is in my bio. And I would get on the protocol that is specifically for diminished ovarian reserve, because even if you don't have diminished ovarian reserve at 43, that full protocol will help you. I would also consider using growth hormone, and I would consider being on metformin. That's kind of the full court press about what we can do with Western medicine for egg quality. And I don't know if it's really Western medicine because our vitamins really part of Western medicine. I believe in them. I believe that supplements really can do a lot for us. But evidence-based practice is really a good thing, because you could easily go to the GNC and buy yourself $500 worth of medications that the professor behind the counter at GNC, who may or may not have graduated from high school, tells you are good, when they really may not be. So follow the evidence. If it's a good thing, it's probably been studied. And if it's been studied, then that can tell you really where to go. Let's see. We'll go back to the CNY side here. Can Orilissa cause menopause for a 42-year-old with an AMH of zero point 0.2? Can the ovaries recover from it? Yes. So the suppressive effect from Orilissa is temporary. There is no, even Lupron will cause a temporary menopause, but I would expect as long as you've got eggs in the ovary, and zero point 0.2 as an AMH means you are limited in your ovarian reserve, I would expect you to come back from that. So no, I do not think Orilissa is a cause of permanent menopause. Amy Lorraine, does anyone have been seen by them with TRICARE? I guess if you're asking, do we take TRICARE? I believe we do. Miracle Baby to Come, is DHEA and androgel important for older women? So, using testosterone is one way that we can sometimes improve egg quality, and I will do it in some scenarios. Um, and I usually use androgel. Makes it easy in a little packet. It's the 1.25 milligram packet that's used really just during the stimulation. DHEA is really far, I think, is far better. There's very substantial evidence, a lot of evidence looking at DHEA, which is a precursor to testosterone, at 25 milligrams 3 times a day, specifically for egg quality. So, irrespective of what your DHEA level is, DHEA is said to be one of the top 2 most important things for women with diminished ovarian reserve. The first is CoQ10, or ubiquinol or ubiquinone, and the second is DHEA. DHEA is 25 milligrams 3 times a day. I don't care if your level ends up to be 750, which is pretty high. For the short term, that is helpful for egg quality. Kaliasi, the number one thing to improve your poor egg quality. Well, maybe I just said that. I think it really depends on, I think it's the list of supplements. And again, there is a list for those with normal ovarian reserve, and there is a list for those with diminished ovarian reserve, or really those over, I would say, about 39 years old. And I would say that is the easiest place to start as far as improving egg quality. 1111, Make a Wish. Okay. Let's see. I think I answered some of these things. Did I go back to the start? Essence Marie says, what makes you have a fresh transfer instead of frozen? Well, the fresh transfer is included in the price, in the cost here at CNY Fertility. So if you have enough embryos and you can do it, go ahead and do a fresh transfer. As we get more mature, so let's say for women in their 40s, a fresh transfer becomes significantly less successful. And in everyone, really, a frozen transfer is always going to be more effective. But as long as you're here, if you've got the embryos, it's included in the cost. Go ahead and fresh transfer is okay. Now, there are some scenarios where we'll tell you, no, we don't want you to do it, that the hormone levels are telling us that you are not in a good place to receive that embryo. Because again, remember, you are in egg making mode when it comes time for IVF, and that may not be consistent with being pregnant mode. So got to keep your eye on those hormone levels. Let's see if we've got time. Nice glasses. Well, thank you very much. So you got to, again, got to dress it up. Try to do something a little different every week. Jamie Marie Newton, 32 years old with 3 prior pregnancies, all conceived on the first try. Need IVF because I had a tubal ligation. My AMH just came back at 9.1, which is higher than expected. Should I be concerned? No, but it means that we would want to dial back your stimulation medication, because I don't need you to make 75 or 100 eggs. We go for quantity over quality, then you suffer from that. So what that AMH tells me is that we pull back on the medication so that we don't hyperstimulate you. and can work really more directly on getting you good quality eggs. It is time for us to wrap here, folks. It's been a great Tuesday with you here on Fink and Friends, and I enjoy every minute of every Tuesday I get to spend with you. Thank you so much for spending your precious time with me. The thing to remember is that, kindness, there ain't enough kindness in this world. Look at the internet, watch the news. Anything that you can do to add just a little dabble of kindness into this world we live in will really have a ripple effect and go a long way. And I honestly believe that every step forward with love and every step forward with hope, because tomorrow is a new day. The sun rises and it brings us all new things. Forget about what happened yesterday, because tomorrow we start afresh. Have hope. This fertility business is not the book of your life. It is just a chapter. And what are we doing? We are here to rewrite it together. So until next week, thank you so much for being with me on this Tuesday evening. I am Fink. You are friends. And I'll see you next week. God bless.